Good morning, and welcome to this edition of Medical Minutes, brought to you by Passavant Hospital. I am Dr. Peter Russotto, your host and moderator. The topic today will be hospice care. I have in the booth with me Deb Wiston, who is a hospice RN and clinical supervisor with Memorial Home Services Hospice. Hospice care is a topic people sometimes feel uneasy talking about. Today, I hope we can shed some light as to what this wonderful organization can provide for you or your loved one. I know from personal experience and from communicating with many families, hospice care is nothing short of phenomenal. I have yet to hear anyone saying negative thoughts about their loved one's decision to enter hospice care. So, as I turn to Deb, welcome.
Thank you. Thanks for having me.
Basically, what is the overall goal of hospice care?
The overall goal of hospice care is for patients who are no longer actively treating for a cure for their disease process and they have a terminal prognosis, is for us to provide pain and symptom management for the patient and emotional and spiritual support for both the patient and the family.
So when is the right time for people to be referred to hospice or even consider it or talk about it with their physician or their loved one?
Well, I think as a patient has been treating for a disease process, whether it's cancer or another disease process, and they are getting to a point where the burden of treatment is greater than the benefit of treatment. They're entering that treatment phase and they're wanting to have just comfort measures only. That's a great time to talk to the physician about what kind of services can hospice provide for me. We have a lot of patients that are referred to us very late in their disease process. We have patients that are with us maybe just 7 days or less. And that's really too short of a time to take full advantage of all the services that hospice has to offer. In fact, nationwide, the National Hospice and Palliative Care Organization tells us that about 35% of patients that receive hospice care are with hospice 7 days or less. And so in an effort to encourage people to look to hospice sooner, we encourage them to start talking to their physician as they're starting to think about, maybe I want to stop treatment and I just want to stay comfortable. I don't want to keep going back in and out of the hospital and want to stay at home.
So for your purposes, of course, you would rather have that conversation as early as possible.
Absolutely.
It's almost really never too early to discuss it.
No, it's not. I mean, we don't want to take hope away from people, and there are a lot of disease processes that can't be cured. But sometimes off the front that there's a possibility there may not be a cure. And if that happens, what's the treatment option then? I think if we can encourage people to look at hospice care as end-of-life care as part of the continuum of healthcare, just as you have neonatologists who are taking care of babies, pre-birth, we've got people who have the specialty of taking care of patients in their final weeks of life and providing them that comfort and support that they really need.
I think the listening audience needs to know, and you can educate me on this, it's a mutual decision. It's not just a decision that the physician makes. It's really not a decision sometimes just the patient makes. It's for the overall collaboration of ideas and what's best for all concerned.
Absolutely. You hit the nail on the head. This is a conversation that needs to occur with the physician, the patient, and their loved ones. And what time is the right time to make that referral? What are their goals of care? When is the right time to make that referral to hospice? We don't ever want a patient to be forced into hospice services. A physician has to be able to officially certify that that patient has a terminal prognosis and is appropriate for hospice care at this time. So it's a team approach, a team discussion.
And it's not even a permanent decision, because some people think if they just turn it down now, they can't go back later. I'm sure you can tell the listening audience that's not true. Somebody might say they're just not ready for it, and then 2 weeks later change their mind, and that's okay.
That's correct. In fact, a lot of times we'll have a referral for information only, where we just go and talk with the patient and the family, give them information about hospice services, let them know what all we can do for them, knowing that they may not choose to have hospice services at this time, but as they go on down the road, that will become an option for them. The other thing that I would also point out is a lot of people think once you're in hospice, you can never go back. And there is the option if a patient wants hospice and they enroll in hospice, but then they decide later that they'd rather pursue active treatment, they could always opt out of hospice services. So they have a decision. They have the option to have hospice services or not.
Many people think that hospice is only for people with terminal cancer. However, I know that's not true. Mm-hmm. Can you tell our listening audience the many end-of-life pathologies you deal with then?
Absolutely. End-stage cardiac disease, end-stage lung disease, end-stage renal disease, kidney disease. We have patients that have ALS, Parkinson's, Alzheimer's, dementia, HIV. So, for instance, a patient who has had a lot of cardiac issues throughout their life, and maybe they've even got a few other disease processes going on, what we call comorbidities, they get to the point where really what treatment they're taking is not benefiting them. End-stage congestive heart failure, is one that we see a lot for our patients. End-stage COPD is another one. So
even like some of the neurological disorders, I'm sure.
Absolutely.
ALS, mm-hmm. Skeletal system disorders, mm-hmm. and everything. Mm-hmm. And I'm sure each individual case is tailored to that patient's special needs or desire, so to speak.
Exactly. What we do when we admit a patient to hospice services, we do a full assessment, and we talk with the patient and the family about what are your goals for care. We find out what symptoms are bothering them, if it's pain or other symptoms, and then we talk about what we can do to help relieve those symptoms. We also, I think one of the unique things about the hospice program is we have an interdisciplinary team. And so we have the nurses that are seeing the patients to take care of their physical needs. We also have social workers that help to provide some counseling and support to patients and their family members. We also have chaplains on staff that can meet with patients and family members about spiritual needs. And we also have volunteers who can come and sit with patients and provide extra socialization or provide a little bit of respite for the family members. We also have home health aides that can come in and provide personal care to the patients, help them get bathed and dressed. Sometimes that's very taxing for patients as they're starting to decline more.
I'm glad you brought in the point about working with the religious, because some people feel that, well, if they're just in the hospice care, they can't have the comfort of their pastor, but that's not true.
It's incredibly important, especially at end of life care, to have that spiritual component. There are a lot of things that even people who have a strong faith still, have questions, have concerns, and need to dialogue about some things. They need to assign meaning to their life and have a peace about what's going to happen and where they're going to go. So that's an incredibly important component of what hospice care is. We have hospice chaplains on staff that can visit with patients, but we also encourage patients' own clergy to visit as well. So we don't want to take that relationship away from them either.
I know some people feel that if they go home and they're not in the hospital setting, one of the big concerns for all end-of-life issues is pain. Mm-hmm. And they wonder, how can this be controlled in a home setting? You have many ways, I'm sure.
We do. I mean, we have medications that can be given orally. We have medications that are on a patch that stick on the skin. We can also do IV routes. We can pretty much do any treatment that you can have in the hospital. We can provide the medical equipment that we need to keep the patient comfortable. So if the patient needs a hospital bed so the head of their bed can be up and they can breathe better, we can provide that. We can set them up with oxygen, a bedside commode, wheelchair, walker. All of that is provided by hospice through the hospice benefit.
That's a good point. So you coordinate the durable medical equipment that is also needed for them to be in an at-home setting.
Exactly right. We have, for the hospice benefit, it covers the cost of all the services on the hospice team, which I mentioned a few minutes ago. It covers the cost of the medical equipment that we need to keep the patient comfortable, and it also includes the cost of the medications that relate to the patient's terminal diagnosis and for pain and symptom management. All of that is included in what the hospice benefit covers. So for patients, for instance, that have Medicare has a hospice benefit. We accept Medicare assignment. So there's no money out of pocket for the patient. It's a benefit that they are entitled to have that quality end-of-life care through hospice.
Would you say that most private insurances also provide this?
Yes, Medicare, Medicaid, private insurance. We do sometimes have patients that are self-pay. If we have patients that don't have insurance, we have our social workers assist them to see if there's any financial help out there that can help offset the cost. But we don't turn anybody away based on inability to pay. We want to work with them and make sure they have access to hospice services.
So how does hospice provide support for the family in addition to the patient?
That's a huge component of what we do. We provide a lot of support to the patient, but we also provide a lot of support to the patient's family or caregivers. As the patient's condition starts to decline and they are not as communicative with us, we're providing information to the caregivers on what to expect, how to give the medications when we're not there, what different meds are for what symptoms, and how to handle those situations, and also providing them information about this is what we see now with our assessment, and these are the things that we expect to see here in the next couple of days. Giving them information about what we anticipate we'll see. For instance, one thing that happens to patients is they have periods of apnea or periods of time where they're not taking a breath. And that's normal and it's not painful to the patient. But if we can let the caregiver know that they may see that, and it's not painful to the patient, and it's not anything to panic about, that helps them to cope a little bit better when that change occurs.
Education is always a plus for those individuals.
Absolutely. You know, the fear of the unknown is huge, and so what we try to do is come alongside the caregivers as they're walking this path with their loved one and help them through that, help them understand what's going to happen and what impact that is and how they can keep their loved one comfortable. It's huge.
Well, what brought you to your work in hospice?
Well, believe it or not, I wanted to be a nurse. Even as a very young girl, I mean, probably 2 or 3, I think I talked about being a nurse. I always wanted to work in OB-GYN. So I always tell people God has a sense of humor because I'm working on the opposite spectrum. But I started doing home care in 1995, and I had the opportunity to help with hospice on-call rotation. And as I worked with that population of patients and their families, I realized that is really the area of nursing that I felt most fulfilled in. I feel like we make a huge difference for people at that time of their life. I think everyone on the hospice team has a similar story where either they've had a personal experience with a family member or friend in hospice or something like that propels them to really be there and reach out to people in this stage of their life.
As I said earlier, I never heard a negative comment about anybody in hospice. Is there any other additional information or contact numbers, or how do people who are thinking about hospice get a hold of your organization other than maybe through their physician, but if they want to talk outside of their physician?
Sure, absolutely. If people have questions and they'd like to talk to somebody about hospice, they can call 217-788-4663 follow the prompts to talk to someone from hospice, and we'll be happy to give you more information and also kind of talk through your situation. Another good place to go to is www.memorialhomeservices.com, and there is on the left side of the home screen a hospice banner. If you click on that, it gives you all kinds of information about the services that we provide. One of the features that I really like is there's a frequently asked questions and hospice myths that we like to have people read through. So it's a great resource for people to check out online.
Well, great information, Deb, and thank you for being with us this morning. And to our listeners, thank you for listening. And